Hello, everybody. Here is Dr.Cavezzi. I want to thank sincerely Oscar Bottini and all my friends in the International Union of Phlebology. I'm sharing my desktop to start my presentation concerning complications of sclerotherapy of varicose veins. This is my disclosure slide, and I have nothing to disclose. So my presentation is based, for example, on this consensus document, which was released a few years ago, where you can see clearly that the vast majority of the possible complications are not common, whereas the most common ones, as we will see, are, for example, matting, pigmentation, and so on. So another article which I wrote together with Kurosh Parsi focused on the complications of foam sclerotherapy. And this is another article from Malay Patel as well, where he reviewed his own experience concerning complications of sclerotherapy. This is an article which I published a few months ago, where I tried to highlight all the good and bad, let's say, in phlebology and even more in medicine, concerning research, concerning literature, and so on. For example, concerning sclerotherapy, what was highlighted in that article, thanks to the O'Donnell study, was that the DVT rate and the PE, the pulmonary embolism rate in sclerotherapy, was respectively 0.8% and 0.2%, which was clearly lower than other varicose vein treatment situations, as you can see here. And the same is true for neural lesions in sclerotherapy in comparison with endovenous thermal ablation or surgery. This is just to highlight since the very beginning that somehow sclerotherapy has a quite lower rate of complications. Which are the complications of sclerotherapy? As you can see here, we have some general complications, such as the typical ones, the clot retention, the pigmentation, the matting, and so on. Furthermore, we may have some complications which are related more to foam, for example, such as visual disturbances and the pulmonary gas embolism, and so on. We will detail in a while most of these complications. Let's start from the allergic ones, so anaphylaxis or anaphylactoid reactions. Of course, let's say that dermal local skin reactions are much more frequent than the general anaphylaxis, as you can see here. And in general, foam sclerosants are less prone to give anaphylaxis or anaphylactoid reactions. Localized urticaria is possible when we perform sclerotherapy. It is usually of transient nature and it lasts around 30 minutes. Probably it is due to histamine and other cell degranulation factors which may highlight this bulle after some allergic reaction to the sclerosant agent. Let's move now to a very important topic, which is deep vein thrombosis related to sclerotherapy. Again, sorry. Okay, here we are. So which is the incidence of deep vein thrombosis after sclerotherapy? This is extremely difficult to report because there are several ways to investigate deep vein thrombosis, though we know that duplex investigation would be the cornerstone of any report about these possible side effects. Somehow, I would say that from literature, we can see that around 1% should be the proper rate of the deep vein thrombosis, including, of course, the distal vein thrombosis together with the proximal, so the femoral, popliteal, or iliac thrombosis. And this is, for example, the case of Gillet from France. Though the majority of the DVT were highlighted in all literature data in the lower leg. One of the possible most important factors to influence the rate of DVT is the dose of the foam when we perform foam sclerotherapy, which is injected. In this article from Ken Myers, you see that keeping the dose up to 10 milliliter helps you let's say, decrease the DVT rate. Concerning pulmonary embolism, things are even more complicated because we mostly rely on, let's say, symptomatic pulmonary embolism, and we have basically no data on silent pulmonary embolism. Again, GIE reported one case out of 1,025 patients treated with sclerotherapy. Conversely, superficial venous thrombosis under the form mostly of a varicophlebitis has a much higher rate. We could say from nice investigation, nice survey, that it should be around 4 or 5% of the cases the cases treated with sclerotherapy. We lack a definitive definition, let's say, and we know anyway that the superficial venous thrombosis may extend to the deep veins and induce deep vein thrombosis. Also, we know that it may occur weeks after foam sclerotherapy. So from the European consensus, we see here a few recommendations, which I will not read, but as you can see, basically, it may be interesting to investigate the patient prior to sclerotherapy, especially when we have a family history which is suggestive of any possible thrombophilia. And also we should use some pharmacological thromboprophylaxis together with, for example, compression stockings and movement in a few cases. I mean, compression stockings, I would recommend in the vast majority of the cases, but thromboprophylaxis in terms of pharmaceutical thromboprophylaxis, that would be probably reserved to specific cases. Reducing the volumes would help to reduce, as we saw, the venous thromboembolic risk. And anyway, again, we should decide on a case-by-case basis. Now we move to the neurological events. Again, it's not easy to report about the real incidence. So somehow the overall frequency varies from 0 to 2% when we look at literature. And anyway, the vast majority of these adverse cerebral events are linked to the right to left shunt presence. I mean, for example, the patent foramen ovale. So visual disturbances and migraine could be considered cerebral events, though we know that the visual disturbances are part of a migraine attack. And there may be an association again with the right left shunts, such as the PFO. And a few authors, such as Frulin and others, have shown an increased level of endothelin in these cases. With CO2 or CO2 plus O2 based sclerosant foam, Nick Morrison reported fewer visual disturbances when performing sclerotherapy with the sclerosant foams. When we move to TIA and stroke, though they are quite rare, they are of course of important clinical relevance. So, for example, you see sparsely 2 cases out of 4,059 foam procedures. And if we look at this literature review from Raymond Martinbeau, she investigated articles where more than 11,000 patients were treated, and she found quite low percentages of stroke, 0.01%, and of TIA or RIND, RIND, 0.06%. Of course, a higher rate of visual disturbances and migraine was reported in these studies, 1.26%. So again, well, it is important to consider that when we have a TIA or stroke, it is important to differentiate the immediate onset, because that could be a matter of gas embolism, from the delayed onset. For example, a few days or at least, let's say 12 or 24 hours, because in case of delayed onset, we may face a paradoxical clot embolism, because we have the time to get some clot formation waiting for a few hours. And then when you get some cerebral event, it could be the case of a clot embolism. Again, the right to left shunt is probably the most important risk factor in all the reported cases which were, or the majority of the reported cases which were encountered in literature, and higher volume of sclerosing foam may contribute as well. A few adjuvant measures have been advocated but not validated to reduce this possibility of TIA and stroke. We know that patent foramen ovale is present in about 25, 27, we see here, percent of the total population. But the mean diameter of this patent foramen ovale is around 5 millimeters. On the contrary, when the patent foramen ovale is symptomatic, the mean diameter of this hole in our heart is around 11 millimeters. So how could we screen PFO? First of all, history taking. Whenever we have a patient with migraine and also with aura, and even more when the patient had a cryptogenic TIA or stroke, then, and especially in the early age, then we should urge some more investigation about PFO, let's say. And probably the transcranial color duplex ultrasound is the more reliable, so we can investigate the middle cerebral artery to detect any possible passages from right to left heart. So these are, again, the European guidelines about the recommendation. Just for example, when we have a PFO, if you want to perform some sclerotherapy, then the patient should be immobile for a long time. You should avoid large volumes and especially avoid any Valsalva maneuver after the treatment. Again, if and how you should treat the patient, it should be decided on a case-by-case basis. Tissue necrosis, it's due typically to extravasation, but when you have tissue necrosis, you should consider the possibility of an inadvertent intra-arterial injection, but especially of a veno-arterial reflex vasospasm, because this is possibly the most advocated mechanism in these cases. You see here a case of mine where I detected some very slight tissue necrosis because a real necrosis did not come out. But anyway, I saw this skin alteration some 30 centimeters below the point of injection. That's why we should think about these, let's say, arteriovenous shunt, venous arterial shunt in a few patients. The real arterial injection is another issue. And we know that when we treat, especially around the small saphenous area or around the popliteal area, the malleolar area, we should pay a lot of attention to the arteries because we can directly inject the artery, which would, of course, cause a lot of problems to the tissues, to the distal tissues. And in case of major vessels injected, also amputations have been reported. Anyway, we should use ultrasound imaging to inject dangerous areas. Let's say, keep out of perforators. You don't need to inject directly the perforator. You can clearly inject the vein, which is in proximity of the perforator. You can use catheters, and if in doubt, pull it out. This is always a good suggestion. Nerve damage is quite rare, as you can see. And again, small saphenous vein area is one of the most risky ones. Lymphedema is possible after sclerotherapy, and the incidence is a little bit underestimated. In my experience, I got 0.5% of lymphedema after sclerotherapy, but especially again in the small saphenous vein area where you have the lymphatics which are really stuck to the small saphenous vein trunk. And again, when patients undergo calcium channel blockers or alpha lytics, they are prone to some higher lymph stasis incidence. That's why in these patients, you may get some more edema after sclerotherapy. Now we move to more common complications, such as a telangiectatic matting. And as you can see, it is mostly of transient nature, and the incidence can vary from 5 to 24%. It could be due to some estrogen alteration or some genetics. But again, you should not inject with high pressure. You should not inject high dose, high concentration. So, and always you should treat the major refluxes and also the reticular veins which can possibly feed the telangiectasia. And waiting for some 3 months is a wise suggestion, let's say, and somehow retreating the veins with the proper concentration or even with laser could be an option. Clot retention is probably the most common, together with pigmentation, the most common side effects of sclerotherapy. It's relatively common in large varicosity treatment, and invariably pigmentation follows. You can remove it via a needle, and anyway, it cannot be considered a real varicophlebitis as it is a real clot retention in the treated vein. You see here a classical example of trapped blood in a treated vein. And as you can see here, the incidence is absolutely variable from 7.8 to 55%. Again, we need more reliable data, and invariably pigmentation follows. So pigmentation is by far most common sclerotherapy complication. It is around 20 to 30% probably at short term, but at 1 or 2 years, the incidence is much, much lower. That's why the Americans told in a couple of congresses that the best treatment is time. The longer you wait, the better the outcome. But anyway, we know that you can treat pigmentation with some creams or peelings and so on and so on. So as overall, as we saw since the very beginning, there are not so many important complications when you use sclerotherapy to treat your varicose veins. You have to keep in mind that foam can be related to some specific complication, as you see here. So in conclusion, sclerotherapy is effective and generally safe technique. Major complications are rare, but they may be clinically significant. That's why we need a good technique, an adequate imaging prior to injection, and general precaution and compliance with post-treatment instructions surely help to decrease the adverse effect. And also we can do something once the adverse effect has come. Lower volumes means also somehow a lower rate of thromboembolic and gas-related complication when we perform foam sclerotherapy. So I sincerely thank you all, and I thank a lot of friends who helped me also in this, let's say, presentation of mine. So thank you very, very much for everything. Bye-bye.